So we have a personal opinion about question one. So are you wondering what the correct answer was? So I felt like I did well or I got it backwards. Well, there's always that. Um, so the question required you to think about flow dynamics. So is that whole, so vascular remodeling is part of it. So is that whole slide where we talked about things that impact flow, being pressure gradient, um, directionality, or viscosity, all those things? Right. So if the person has hyperlipidemia or has plaques, they have the biggest issue they will have in terms of flow that could potentially lead to ischemia is turbulence related to a disruption of the laminar flow, which can cause clots to form, um, which can cause friction damage on the plaque itself. So something regarding disruption of flow in, as far as increasing turbulence of flow. In terms of hypertension, the vasoconstriction, and which could then over time lead to vascular remodeling, changes the resistance of the vessel, and a change in resistance, an increase in resistance decreases flow. So the answer was um, resistance and turbulence, essentially. Something to that effect. I mean, it doesn't have to be exactly that, but at least in your description, that's what you're describing. Is that good or bad, Michelle? Well, I got part of it. Okay. Yeah. Okay. So, because um, that's the whole problem with those chronic health conditions is that ultimately, because the main job, well, three-fourths is good, the main job of that system, of the vascular system, is to move blood, oxygen, nutrients. If there's anything that hinders that flow, then tissues get damaged. So it was trying to apply that, put that all together. So it was a hard, I agree that it was a harder question. Any other questions about the exam? Because, oh, Candy is typing something. No, thank you for explaining that. Okay, so I mean, obviously, I will be looking for the terminology, but if you're describing the fact that the resistance in some way, the constriction occurs, or that there is more likely to form clots or whatever. I mean, that's essentially the same thing. Um, so I'll have to read it. Oh, that's a few. Okay, I wasn't sure if that was like a face palm. It's hard to tell on the picture. Okay, so what I wanted to look at first was what is coming up in the next, because we're on the bottom half of the hill here. We're almost done because this does go pretty quickly. It's kind of amazing. I always think that these summer classes feel like 2 seconds and 20 years at the same time because it's a lot of work for everybody. So let me just see. I'm trying to find my Moodle. Okay. If we go into our class, where are we here? Here we are today, July 9th, where we'll be going over GI and respiratory function. Um, the class after that, July 16th, is kidney and endocrine. And then July 23rd, our last class, there will be an exam on the information that we go over on the 16th. So kidney and hormone function. And then we're all going to meet together to do the cancer presentation. So I think, I don't know what I put here. There's some extra information about cancer presentations in here that I believe you don't need. So I'm going to get rid of this so it's not confusing to you. That was information that was needed last class when we had to quick put things online and I had to do the presentations in a different way. So you can ignore that and I will get rid of it. What you have to do for the cancer presentation is obviously, I've told a couple of you this. After the exam is over, I'm going to have a little cup with your names in it. I'm going to draw names. Whenever it's your turn, you will be given control of the presentation and show your slides like I do for the class and give your presentation. And that is, people can then ask you questions after you're done, including myself. And then I would ask everybody to just jot down a couple of notes that you might share with the person who did the presentation via email. You know, you did really well with this part. This part you maybe could have used a little more polishing because you said a lot or something like that. Just helpful things that can be used in terms of improving their own presentations, because you'll obviously have to give presentations a lot. So in that cancer presentation Dropbox thing on Moodle, you'll also see this. This is your cancer presentation self-assessment. So I think most of you have taken Alverno classes already, but Alverno is obviously big into self-reflection. How can you use what you've learned in your future job as well as in future classes? So during your after your presentation, and some of the reviewing some of the feedback you've gotten from your peers, you will reflect about the presentation, what helped you most when you were working on this presentation. If you could do it over again, what would you do differently? And based on feedback you received, is there something that you would do differently? Just kind of thinking about what you would do for other presentations. So you would fill that out and upload your cancer presentation PowerPoint, your final draft, to this Dropbox, and that's where you'll get feedback from me on the presentation itself. The other thing that's listed in here is the final assessment. So this is the final project, which is sort of like a take-home exam. In these documents, there are directions, there's a patient, and then there's where you would write your own self-assessment and where I will put my feedback. So I just want to briefly go over the directions so there's no question about what you're supposed to do. And this is just why this, what we're supposed to be accomplishing through this final assessment. So it's a review of our course outcomes and criteria. In order to be successful in this assignment, you would have to recognize types of cellular adaptation. So that means going back to the first class when we talked about things like atrophy, hypertrophy, those types of processes, pathologic or intracellular accumulations, things like that. Looking at the cellular response to injury, predicting the results of diagnostic data. So if someone has this problem, what would you expect their lab results to be, or how would you explain their lab results? And then looking at the interplay of multiple illnesses, because that is what this patient will have. That's the criteria which you're being looked at when I'm going through these assignments. And so these are the directions. You will read the subjective and objective data about this patient and use your text highlight color function to highlight everything that's abnormal. The diagnoses of interest will be listed at the end of the clinical note. So there are more diagnoses the patient carries than you have to explain. And under each diagnosis, provide a list of all supporting clinical information, subjective, objective, and diagnostics, and then link those things with attention to cellular response to stress and injury. Obviously, the inflammatory process will come into play. It's the same as our other class assignments in which you will be expressing ideas in your own words, obviously based on our class documents, our textbook, our notes, videos, etc., but in your own words. Read it over so that it's readable for me and complete the self-assessment. And so that's all of the directions. This document has the patient information. So it's a big, longer case study than what we've had. So there's this patient, they have this health history, they're coming in describing some symptoms they have. The provider is going to be doing a physical exam, and they have received some lab values. So there are many assessments, many diagnoses under here, but you only have to, under the selected diagnoses, provide a list of supporting clinical manifestations that you've highlighted in the body of that report. So that's one diagnosis. It's a long one. Acute hepatitis leading to post-hepatic bile obstruction and pre-renal AKI. So it's actually 3 things, because that's the acute issue. And then there's some questions about chronic, acute and chronic issues. So there's 3 questions. It's worth 100 points. So my suggestion is to look at it now so that if you had any questions or things, you might be able to ask me prior to when it's due. So the other thing is, what kind of questions can you ask? You can't, you could just say, this is what I'm thinking, am I in the right direction? And I wouldn't give you the answer, but I would tell you if you are, or if you need to think about it in a different way. This last document that's in here is the self-assessment that goes with this assignment. So thinking about the assignment, the final assessment, what was the hardest? How did you get through it? Because these are things you can use in other classes, and identify how you're going to use this in your chosen practice, this way of thinking. And this is where I will put my comments about whether or not you've met the criteria for the assignment. So those last 2 assignments, those last 2 things on July 23rd, both the final assessment, which is due actually later on, July 27th, and the cancer presentation that is due July 23rd, are worth a significant amount of points, which is why I wanted people to start the cancer project early, to be sure they're on the right track, and why I want to be sure you take a look at that final assessment before the last minute so that you have enough time and enough time to process it in case you have questions. So yes. So you don't have to describe, that's probably what would be ordered, but you don't have to describe it. Noelle was asking about the ultrasound being blank, so you don't have to worry about that part. Excuse me. Any other questions about things that are coming up? Because otherwise we're following the same pattern for the next week, where there'll be a case study that opens up after class, and obviously an exam on this material. When we come back together, but we're getting towards the end here. So then I will start talking about respiratory and GI. So I'm recording. I will put up what I record, but again, this was material that I ended up having to make videos for on YouTube, so I will post a link to those video lectures too. So you can watch it that way if you prefer, instead of just seeing the screen. You can actually see me in my dining room fireplace area that I turned into like a board. Okay, so we'll start with respiratory. The respiratory system really has three main parts to it. There's the movement of air between the atmosphere and into where the breathing portion is of the lungs. And then there's the diffusion of gases in the air-filled spaces of the lungs. So typically as a nurse, you may have talked about the lungs in a general way. You know, if there's a problem, it's the lungs. But what we need to clarify is the lung problem within the tubes, or is the lung problem within the lobule, which is the alveoli and the blood supply, where the gas exchange takes place? Because those are two separate issues, and they cannot, you have to think about them separately, where you might not have before. The other issue is that the respiratory system has a dual blood supply. Part of the blood supply is what's coming from the right side of the heart, that is the deoxygenated blood, where then will interact with the alveoli for gas exchange. The other part is what's called the bronchial circulation, which is really just there to support and warm the air and to provide the opportunity for gas exchange for the lung tissue itself. The lung parenchyma, which is the spongy tissue, and the cells of the lung tubes, because they also have oxygen and metabolic needs. So the two types of respiratory tissue that we're going to talk about in terms of how they affect oxygenation and what kind of diseases they're prone to are the conducting airways, whose main job, there's no gas exchange there. It's just simply about taking air from the environment and getting it into our chest, and then taking that air that's inside and pushing it out. And then the respiratory tissue, or the lobule, which is where the gas exchange takes place. So we'll start with the conducting airways. And these are what is encompassed in the conducting airways: the nasal passages, mouth pharynx, larynx, which has the two folds, both for vestibular folds, which are to help cover the larynx when you're eating, and the vocal folds for speaking: trachea, bronchia, and bronchioles. These have they have a special cellular environment that is part of our innate immune system, because it's creating a barrier to help prevent infection in this area. So it is supposed to be made of squamous epithelial cells that are tightly together with those adhesive molecules. There are goblet cells in this area which create mucus. The blood supply to the bronchial, to the conducting airways, warms and moistens, humidifies the air, and then foreign material or microbes could end up stuck in the mucus, and then the ciliary blanket in our cough, which is the elevator, can help expel those things before they can lead to an infection. So this is an essential part of our first line of defense, the barrier. We know that one of the ways that cells adapt to stress is to change type, which is metaplasia, which can happen in the airways, especially in exposure to chronic smoking. That's chronic irritation will then change from squamous epithelial cells with beautiful cilia and mucus producing cells to cuboidal cells, which do not provide the same mucus protection and mucociliary blanket with elevator of secretions, which is one of the reasons why smokers are more prone to bronchial infections. And that's the beautiful picture of that airway when it's intact. The other type of lung tissue is the lung lobule, which is the alveoli, that's the little grapes at the end of the conducting airway, the terminal bronchi end with the alveoli, and the spongy tissue, which is called lung parenchyma. The lung lobule is where the gas exchange takes place, or diffusion. Those alveoli are made of type 1 and type 2 cells. Type 1 are squamous cells, and type 2 are the cells that produce surfactant, which help keep the alveoli from collapsing every time you breathe. So we always want to keep some air in our lungs in the bottom alveoli, or they will close and stick to each other, and then it takes that much more effort to open up our lungs with inspiration. So what I just described really was atelectasis, when you're not allowing air to remain in the alveoli after expiration. So I know there's a lot of you that work in critical care, and so what we're really talking about is PEEP, which is positive end expiration pressure. We want to keep some air in the alveoli to keep them from collapsing and touching these walls. You don't want these walls of the alveoli to touch each other, because then it's harder to open up the lungs after. If that would happen, we do have a protective, our protection is surfactant, which helps to keep the alveoli from sticking too tight together, so that it's easier to overcome the surface tension of the alveoli collapsing. So the next question is, how are we going to get air into the lungs? And we have to then talk about things that we talked about when we talked about blood vessels and moving fluid. There's similar things that we have to talk about. Flow equals a pressure gradient divided by resistance. That's what we talked about in terms of blood vessels. We wanted increased pressure on the arterial side, less pressure on the venous side, which helped propel blood forward. And if the blood wasn't too viscous and the diameter was big, we keep the resistance down, which also increases flow. So this pressure gradient and flow have a direct relationship, meaning when pressure gradient goes up, flow goes up, and resistance and flow have an indirect relationship, meaning when resistance goes up, flow goes down. This is physics, and that is the same with lung tissue as well. If we can create a pressure gradient, we will allow flow of air into the lungs, and if we keep the air tubes open and don't have resistance in the air tubes, then we will also increase flow. And we accomplish the pressure gradient aspect by the muscles of the respiratory system. And the way this works, you have to go back to your freshman physical science class, which, for some people is longer away than others. Here, if I have two containers with 4 particles, which container is under the most pressure? Whoa, that's my email. Let me see that. So 2 containers have the same amount of particles. One container is larger than the other. Correct. So the container that's smaller, those particles are under more pressure. So I can change pressure by changing the size of the container. And in our case, in the case of the respiratory system, we can change the pressure gradient between the environment and our chest by changing the size of the container. And that is the whole goal of our respiratory muscles. So here we have, my lungs are ugly. That's my lungs. Looks like a plunger, but I never said I was an artist. So here's our lungs. The atmosphere has its own pressure, and the lungs inside the chest has its own pressure. If I want flow to increase from outside to go into this tube, and into the lungs, I have to create a pressure gradient. And I can do that. I want the pressure outside to be greater than the pressure inside so that the air will flow into the chest. And to do that, I can expand this cavity to make it bigger. And I can do that, I can achieve that with inspiration, because when a person, engages muscles to inspire, they are making the diaphragm go down, which increases the size of the chest cavity. And if needed, there are other muscles that can increase the size of the chest cavity, intercostal muscles and others if there's reason to, if the person is in distress. So bringing the diaphragm down and raising the ribs, I can make this container larger, which will make air move from the atmosphere into the chest cavity. If we now have equal pressure if the pressure between the atmosphere and the lung container, the lungs, is equal, then that's the end of inspiration, because now the pressure is the same, so there's nothing that will pull air into the lungs any further. When I need to blow the air out, I have to reverse what was going on before. Here's my lungs. I need the pressure in here to be up so that the air will be pushed out the opposite direction. And I can do that by changing the size of this cavity to make it smaller. So then the diaphragm relaxes and the intercostals relax, changing the size of the tube, changing the size of the cavity of the lungs, making it smaller. That means the pressure is higher in the chest than it is outside, causing air to move outside. And that's the whole reason we can move air back and forth, is by changing and creating a pressure gradient. The air pressure in the atmosphere is created by a mixture of gases, and each gas has its own partial pressure. This pressure in the atmosphere equals the sum of all the gases in the atmosphere. Primarily, those gases are carbon dioxide, oxygen, and nitrogen. They all have their own amount of pressure, and if you add them all together, you get the pressure of the atmosphere. So each of these is considered a partial pressure. The total is the total pressure. The pressure inside the chest is made up of the intrapleural pressure and the intrapulmonary pressure, the pressure of the air inside the lungs and in the pleural space. And as we discussed, airflow occurs because of changes in the size of the respiratory cavity. So one of the things that we had to achieve was a change in that cavity. If there's something in the lungs, and this is where the pathology part comes up, what if there's something in the lung that's making the pressure in the lung increase? Maybe there's more fluid in the lungs. Maybe there's, something that changes the pressure inside the lungs will make it more difficult. If this is high, the pressure inside the lungs is high because of other reasons, some kind of pathology, then it's going to be harder for us to create the pressure difference between the atmosphere and the lungs. That means the person will have to enlist the help of their accessory muscles, like the ones on the neck that can pull the chest cavity up higher, and the second layer of intercostals. Then we might have to use some of those accessory muscles in order to encourage respiration. The other issue, similar to what we talked about last class, is the compliance of the tissue itself. We talked about compliance in relation between veins and arteries last class. Things that have an increased pressure on them, like the arteries, had less compliance. They had a lot of elasticity because they had some resistance to stretch and a lot of recoil because of the high pressure across the wall of the vessel from the thicker muscle layer of the vessel. The veins had very thin muscle layer, a very low pressure across the wall of the vessel, and easily opened and stretched, but did not have a lot of recoil. That's why, in order to move fluid forward, we needed the help of our skeletal muscles. In the lungs, compliance is a big portion of compliance is the quality of the respiratory parenchyma, the actual spongy tissue. How easy is that to stretch so that I can accept air into the lungs? How giving is the tube itself? So if I have my trachea and the main bronchus and all the different bronchioles that come down into terminal branches into our respiratory lobule where those alveoli are, and that's a lung is obviously around that with lung tissue. If I want air to come down, I have to worry about compliance and resistance. So I want the lung tissue itself to be soft and spongy and easy to inflate. So if there's anything that causes scarring to the lungs, if there, any lung condition that leads to fibrosis of the lungs, it's going to be harder. The lungs will be less compliant. It's going to be harder to move air into the lung. If there's something that scars the bronchioles or lung tissues, it's going to make them harder for them to open and allow air. And occasionally those hard tissues collapse easier, which can trap air. So that is the reason why we might have difficulty. And we do increase the work of breathing if the lung doesn't easily accept air. Airflow, again, we talked about this last class too. We want flow through tubes to be laminar or straight direction versus turbulence. If there's any turbulence, that can lead to making it harder to get air through. So if there's bronchi, if there's fluid in the airways, it's going to be harder to get flow down. And if the airway is compressible, then if it collapses, it's going to be harder to get all the air out. So the next part is diffusion. So we got the air in. There's several things that we had to manipulate. We had to change the size of the container in order to create pressure gradient. We wanted the tubes to be not scarred and able to open. We want them free of any debris or inflammation that would affect resistance, and we want them to stay open and not compress or collapse because that will cause air trapping. And then we want the lung tissue to be spongy enough to be able to be compliant enough to take in. And the whole reason is because we want to get the air down to the alveoli where there is oxygen and carbon dioxide transfer. And this is where we get to the last part of the physics of breathing, which is Fick's law of diffusion. So once we actually get the air down to the terminal bronchus, and here's our alveoli, and then that's our blood flow. We want the air to get down here. We have those special cells in the alveoli of surfactant. And then we have this is pretty close, this is a lot closer than what I have here, between this epithelial cells of the end in the alveoli area, and then the endothelial cells of the vessel is where we want oxygen to move into and carbon dioxide to come out. So these are obviously following concentration gradients too, and we want these gases to diffuse easily over this membrane. And there is problems that can occur here too that would potentially affect how well gases can move back and forth between the alveoli and the blood vessel. And that is what we're talking about here with Fick's law of diffusion. So the rate of diffusion, or how well oxygen can go into the blood supply and carbon dioxide can leave, is based on a constant which you would never have to calculate. That's just the usual diffusion constant, depending on whatever gas you're talking about, times the surface area. So the bigger the surface area, the more you'll be able to diffuse gases. So anything that decreases surface area will decrease the amount of oxygen and carbon dioxide that can diffuse back and forth. There has to be a difference in partial pressures of gas on either side of the diffusion barrier. So if for some reason, there isn't a pressure difference between carbon dioxide and oxygen past this membrane, then we will stop diffusion. So we need a pressure gradient. And then that pressure gradient also has a direct relationship with the rate of diffusion. If there's a pressure gradient, then I will increase the rate of diffusion. The only aspect that has the most effect, or the indirect effect on the rate of diffusion, is thickness of the barrier. So if this is inflamed at all, or there's any change in the thickness between the alveoli and the blood vessel, then there will be less diffusion. So when talking about how air moves in and out of ventilation and talking about how gases go back and forth, diffusion, you can see that there are multiple health problems that can affect both the movement of air in and out and the diffusion of gases across the membrane. Anything that changes the compliance of the lung tube or the pressure in the chest will change the way air can move in and out. Anything that affects the airway itself can change how much air can move in and out. Anything that affects the lung parenchyma, or the sponginess of the tissue, can affect how air can move in and out, which could lead to hypoxia if we can't get the air inside. Anything that affects the alveoli and the vessel can potentially decrease the amount of oxygen that is able to diffuse across into the bloodstream. So surface area is a big thing, and the surface area could be either we've taken out the alveoli for some reason, or we've taken out the vessel, or anything that causes inflammation or a change in the thickness of the membrane here. So that's a lot of infections, pulmonary embolus. Those are all reasons why we might decrease diffusion and again lead to hypoxia. So here we'll take our first break. That's a lot of information. You might have felt that way. Does anyone have any questions before we take our break? Not yet. And we'll review those concepts again as we talk about different pathology, because they go together. So it's about 7:45, so we'll come back at 7:55. Resume here. Flicker. I love lightning and thunder. My faves. Okay. So the next part we're talking about is infections, and of course, that means that it's a revisit of our favorite topic, which is innate and adaptive immunity. So, because it's the process of innate and adaptive immunity that leads to our symptoms, um, um, of wherever the infection is superimposed. So if the infection is in a conducting tube or if the infection is in the lung lobule. So, okay, we just talked about the barrier. We had our mucociliary blanket. We had that. We have our cough. We have some scavenger macrophages near the alveoli. We have the close cells with no with cellular adhesion molecules. If an infection makes its way through that and causes tissue injury, so this would be in particular a bacterial infection, the bacteria releases, hopefully this is all sounding very familiar, the bacteria releases exotoxins that will damage cell membranes and rob our cells of things that we need in order to support their own growth. But they live outside of our cells, not like viruses, a separate entity. So their presence causes a tissue injury. So take it away, vascular phase. Once we have the tissue injury, you skipped a lot there, Amanda. So our neutrophils, the vascular phase is what allows us to get to the cellular phase, which is the neutrophils. But